Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more.
Today we are joined by Dr. Janice Law, a vitreoretinal surgeon and a master educator and mentor. We're going to chat about medical education, curriculum development, all of her experience in education. It's going to be a great one, so stay tuned.
Dr. Janice Law is a vitreoretinal surgeon, holds the Gloria Sternberg Director in Ophthalmology, and is the Vice Chair for Education and also the Director of Medical Student Education at Vanderbilt Eye Institute. Dr. Law is widely celebrated as a retina surgeon and is internationally known for her work in education, including interests in evaluating residency teaching and training, curriculum design and development, and teaching and learning methods. She is a past chair of the AAO Young Ophthalmologist Committee, winner of the Outstanding Female Leader in Ophthalmology for Millennial Eye, a past recipient of the Women in Ophthalmology Emerging Leaders Award, and the AUPO Medical Student Educator Award. She is passionate about mentorship and women in ophthalmology and leadership, and we are excited to have her today on our podcast. Welcome, Dr. Law.
Thank you so much. I am excited. I'm super delighted to be here and be part of your podcast, Dr. Both and Dr. Tooley. Thank you so much for having me.
Well, we are so happy to have you here. I think it's a very apt time. We're in the fall. Mentorship, residency, medical student education is kind of on everybody's mind. So you're the perfect guest to have here, and we're just so excited to have you. Before we kind of dive into all of your work in education, could you just kind of tell us your journey and how you got to where you are, how you got to the job that you have today?
Wow, that's a long period of time that you're asking me to cover. But so I actually went into medical school not expecting to do ophthalmology. I was planning on doing infectious disease, and that's what I was interested in. I really thought it was fun to do, to study microbes and how it would impact disease and people. But then I ended up finding another small thing to be in love with, and that was ophthalmology. It was a chance that I had a 2-week elective over the summer. My father found me the elective at Case Western, and I was able to shadow a cornea specialist. And that's where I got to see the most beautiful work of art, which was a full thickness corneal transplant. And that just opened my mind and my eyes to how I can do surgery, microsurgery, and I can do lots of other procedures in the office and help people, help them see, give them independence and empower them. So when I went back to medical school, I realized over the summer, when I returned back to medical school, I realized that this was going to be a long journey for me to seek out an ophthalmology residency since I had no home program, I had no mentors. This was just a chance opportunity that I had over the summer, and now I need to discover more and more of ophthalmology all on my own. So to fast forward where I am today, I am where I am today because of mentors that helped me through this, but also because I know how hard it was to do it by myself, to be on that journey alone, to seek out what you needed to do just to match into a residency. So by paying it forward, I am able to serve in leadership positions and help others really be the best that they can be and help them reach their goals if they're interested in ophthalmology. When I came to Vanderbilt for my fellowship, I found mentors like Paul Sternberg, who got me involved in the academy, who got me involved in AUPO, which is the Association for Universities and Professors in Ophthalmology, and really connected me with a lot of people in education. And that really just kind of was my springboard to really developing my career here in ophthalmology and in education.
Well, I love that you're giving back. And I think the story that you share is so common with medical students who have an extremely limited exposure to ophthalmology, maybe a day or nothing in medical school, and then by happenstance get to see a tiny little tidbit of ophthalmology and then fall in love and then realize they have a big battle up, kind of climbing uphill to make those connections. Exactly what you described. Like that's still happening today. So I love that that's informed you as a mentor now to help students going forward, since it's exactly what you went through. Do you see still those same challenges in medical students today? And how do we optimize ophthalmology exposure so that we can get more amazing ophthalmologists like you?
Thank you. No, the problem's actually even harder because now we have less and less time in the ophthalmic curriculum. Sorry, we have less and less time in the medical curriculum to teach ophthalmology. So now we are facing just contact hours, contact time. So there was a study in 1994 that found that about 58% of US medical schools had an ophthalmology curriculum. That was in 1994. At the same time, back then, primary care residency directors reported that there was a gap in ophthalmic knowledge as their students matriculated to residency. So they saw that there was a knowledge gap and they asked for more content in the curriculum. Well, now in a study in 2018, we're now finding that only 16% of US medical schools have a required clinical clerkship, and most of the teaching is happening in the preclinical years, in that 1.5 years that they're getting. So now we are being squeezed down to a few hours from where it used to be maybe 20 hours of ophthalmic didactics and contact time, now down to barely 1 to maybe, if we're lucky, 10 hours. It depends on that school. So it's a lot harder now.
You have a forte in curriculum development, mentoring, and relationships. What's the best approach? How do we stay relevant, expose our medical students to ophthalmology? What works, and what way would you encourage people to explore in their medical schools?
So, one, to stay relevant, we have to make the connections for them, help them realize that ophthalmology is in almost in every systems that they are learning, from thyroid eye disease to diabetes to lupus to plaquenil to sickle cell to lymphoma, anemia, and I could go on. We need to find a way to insert ourselves in their curriculum while they're learning it in their preclinical years, and also through their clinical clerkships, and help them make that connection. So we here at Vanderbilt do our best at the Eye Institute. We try to insert ourselves in the geriatrics course, in the course on health equity and social economics, that kind of a course where we can just continue to kind of beat the drum. Ophthalmology is still here. It still affects those types of patients. Access to care. We also go to the pediatric residency, to their ambulatory care clinic, and we teach them how to use a direct ophthalmoscope, because we know that those residents probably didn't get the same training that we would want them to have had in their medical schools. So we go to the different departments and we offer our services, we teach and we mentor and we inspire them to use the direct ophthalmoscope and to make that connection for them. But another thing is, I know there's a lot of controversy with whether or not the direct ophthalmoscope is even important to learn anymore. Because now we have iPhone adapters, we can see the optic nerve, and well, you can easily consult ophthalmology, so why even learn that skill? But I really think that it's important for all directors of medical student education across all medical schools to really emphasize the direct ophthalmoscope as much as they can, because that is that one piece or one instrument we have left that we can then say, this is part of the physical diagnosis. This is the part of the physical diagnosis curriculum. This is something that's important for them to learn as they're learning, just as equally the heart sound, the lung sounds, palpation of the abdomen. Now we need to be able to teach them the pupil exam and the direct ophthalmoscope.
It's such a good point. I think it might have been Atul Gawande that wrote a really nice piece on the art of the physical exam and how we've really lost touch in medicine with the physical exam and how it used to be such an art. And it makes sense because we have all this amazing tech that's probably much better than we are. But ophthalmology still is so much the physical exam. Really, that's all it is before we get all our testing and photos. And I'm glad we're hanging on to that. I'm curious how you've learned how to be an educator and how to create curricula, and where did you get these skills? Because it's not something that's taught.
So I think part of it is role modeling. So we learn from observation and what we're not seeing. So I have reflected a lot on how I learn and how I learn best. I enjoy interaction, and I enjoy when someone involves me. And we know that there's that phrase, tell me and I only remember a certain percentage, right? And you show me, I can only know a certain percentage. I don't know what that percentage is. I can't remember what that quote was, but then involve me and I can remember more and I can actually participate in my own active learning. All that to say is, if we're involving our learners, then we know that we can have an engagement, we can have active learning happening, and so things will click. Then they'll come back for more, and they realize that that is the type of learning that they're going to want. Where did I learn that? I learned it from observation, but I have the fortune too. We have Vanderbilt's Peabody College of Education, and we also have a program called Educator Development Program inside the medical center. And I attend as many of those professional development courses as much as I can to learn about writing learning objectives, writing learning goals, how to assess, how to design a curriculum, and use instructional tools that will actually match your objectives. So that is science in itself, and it's really important for us as if we're choosing to do medical education. It's really important for us to really be able to do that well.
I love that. Can I ask you, do you partner with medical students? Because I've found, as I've become program director, that some of the most engaged and excited people about education are actually students, especially medical students. They all are interested in medical education, and they want to build curricula and do all this cool stuff. Can you get them involved even when they're still students?
I think you are right on. The students who are in the curriculum themselves are the ones who give me the most feedback.
Yeah.
They're the ones who can say, you know what, I think that if we brought this eye model over, or if we can practice microsurgical skills under the microscope, we'd be able to feel what it feels like to have that tactile sense. It's the students who are thirsty and hungry to learn so much that they're the ones who are developing a microsurgical curriculum for themselves.
Yeah.
So we have a few students who initiated that last year. They wanted to find a way to differentiate themselves as they go through the application process, because we recognize everything's pass-fail now in the medical school curriculum, and it's harder to discern who's got what it takes. So they actually created a microsurgical curriculum. And again, I think it's just born out of interest, hunger, and a really desire to excel in the field at an early stage. So I think students have lots of wonderful ideas. They're eager. They have a lot more time, too, to do a lot of the research and the writing. And there's opportunities for them to present that work. And I think it does build on their, I think it helps them build up their medical education repertoire and portfolio. And it just excites them even more when they go into residency.
So Janice, it's exciting to think about that, and they're most engaged. They're wanting to improve what's happening at their institution in exposure and learning. When I think about residents and or even YOs early in the practice, the AAO or our subspecialties have opportunities for young ophthalmologists, let's say, to meet across their institutions to learn from each other. I think most institutions probably have an interest in ophthalmology medical student interest group. And oftentimes at a given institution, there's the leadership structure of that, and they're very involved. Are you aware of whether or not any subspecialties or even the AAO has developed curriculum, a way for a way for ophthalmology interest groups to learn from each other? Because what you develop at Vanderbilt or we develop here at Mayo, it seems like that's a curriculum or a connectivity opportunity to learn from. And ophthalmology interest groups should connect between sites. But is that happening at some level, or is this granular institution by institution?
It is granular by institution. It's separate, but we do have a Directors of Medical Student Education Council that is an umbrella underneath AUPO, like I said before, the Association for Universities and Professors in Ophthalmology. So the MSEs, or the Directors of Medical Student Education, do get together and share best practices. We'll share resources. We'll share links that we have designed and pages that are helpful education-wise. We will share that information, but I think you've hit something on the head there, that we really need to do something more of a kind of a consortium where we can bring it all together in a more organized format so that we can all benefit across the country from each other. I do want to say that the Academy, American Academy of Ophthalmology, has a very robust medical student education page. So if a student had no home program, had no mentors, or had no place to go, if they were to go to the Academy website, they'd be able to find a lot of information about ophthalmology, the basics of ophthalmology, how to perform an exam, and all the features of an exam to be looking for when looking at pathology. So I think that one could learn a lot on their own if they're doing independent study. But also to your point, I think as medical student educators and leaders in this field, we really could do a better job sharing that knowledge and information and really kind of accelerating the knowledge share there.
Yeah, it's interesting that you bring that up, Eric. And Janice, I know you know about this too, and you've spearheaded so many of these initiatives as chair of the O Committee. We have just had the American Academy of Ophthalmology take medical student membership, and that's a new initiative. And we've brought them under the YO umbrella and welcomed them into YO. But there's amazing initiatives that these medical students are doing on their own. So they've created an entire advocacy group, the Future Leaders in Sight. They have over 250 medical student members who are just interested in advocacy. It's incredible. And they're connected across the country. They have webinars and mentorship. They're amazing. And then there's also a coalition of the free student outreach clinics. And there's maybe 50 or 60 clinics across the country that are student-led eye clinics that are all working and sharing their ideas together. And so it's a big initiative of Academy and YO to help bring all those student interest groups together. But it's a new initiative. And I think it's tremendous. And just like Janice said, they're hungry, they have time, they're really incredible. So if you're a medical student and you're interested, or this resonates with you, you guys are changing the world and doing a great job.
I just think too, it's a nice, people that listen to this podcast or to become aware of these opportunities. There's more and more, am I aware that the community practitioners and ophthalmologists, not always the ones in academia, are often involved in medical school education. They've been volunteering to come into their regional medical school for years and just kind of learning about bringing the interest, bringing the opportunity. Some of us, like you, being residency director, you're so invested in the residents or your fellows. You can't invest in everyone group equally. And so having as many educators at the table, informed, educated on how to draw the interest and nurture these young ophthalmology medical students, the better.
That's great. Janice, I also want to ask you about how medical education has changed since the pandemic. Because to me, it seems like the pandemic was a huge inflection point between how we educate pre-pandemic and how we educate post-pandemic. And I know you've published a lot about virtual learning in ophthalmology and different initiatives, and you've really done a ton since COVID kind of changed everything. Have you noticed that change? And has it impacted ophthalmology education from the medical student side for you?
That's a really interesting question. It makes me first jump to thinking about what the lecture hall looks like in the medical school anymore, because there were less and less people attending lectures. And then once we had the pandemic and there were no in-person lectures, now almost it's so hard to get people back into the seats. So I'm just, as you're saying that, I'm just thinking and imagining it. Yeah, things really have changed structurally. It's much harder to get people back together again. And I think we are missing out a little bit about that interconnection and that social connection when it comes to learning. Active learning involves a social connectivity that is been studied before. And so if we're not having that, then we are missing out on that. So what that means is that we have to be a lot more creative. We have to be a lot more creative if we're going to do something virtual or hybrid to create that social connectedness and that interaction. I already use polls and interaction in my slides if I were to present a PowerPoint, so that hasn't changed, but it does make me have to think about how I'm going to get someone on the other side of the screen to respond back and to really engage with the material. I do think it's much harder. I will say that it really did open our eyes now. It opened up, the whole world opened up, I should say. The whole world opened up when Zoom became the platform for us to share information, because now I could broadcast something from Nashville and someone in Seattle can watch the same lecture session or workshop that I have recorded or that I have that I'm broadcasting live. So that really does give us more, one, resources, and two, a bigger footprint of how many people we can reach and the impact we can make.
So I'm curious, when you're giving a Zoom lecture and you have 25 people tuned in, how often are you mandating that their cameras are on? I think all of us like to multitask, but we also realize in education that multitasking really doesn't work. I mean, I think I hear everything my wife's telling me when I'm looking at my sports on my phone at night, but she tells me it's not the case. So I just share any tips regarding educating via Zoom and what you as a master educator have learned. How do you draw them out? How do you keep them involved? But also how to respect that people have busy lives with children and privacy issues in terms of what they're trying to multitask that you're also trying to serve.
Yeah. Well, we do mandate now that the cameras come on. I think that over the last couple of years, we accepted the fact that a lot of faculty also were trying to be at grand rounds and drive their child to school, or, like herd their children into the car. So we understand that is life. When it comes to our residents, however, it is protected time. So we do mandate that they turn their cameras on. When we do have a good group of learners on the other side, when they're on the screen, some techniques I like to use is use the whiteboard. I will allow someone else to engage on the whiteboard and draw. I feel that if they can draw the anatomy or if they can explain it using flow diagrams, they have the ability to teach back. So that's one way we can do some peer teaching. I also use the breakout rooms. So I'll have a topic assigned to breakout room 1. I'll have a topic assigned to breakout room 2. We have 5 minutes to discuss whatever the topic might be, and then we come back to the group, and then we again do some near peer teaching. We'll do some near peer teaching, and then they'll be able to share back what they've learned. Those are just some of the small tips that I use. Mentimeter is something I use. Poll Everywhere, Slido. Those are all things that are helpful to get people engaged to vote. And then we try to convince each other why one answer might be better than the other, or why one journal article may be more influential than another when it comes to some of the topics that we talk about.
I love that. Those are really creative ideas. That's next level. See, great. You're amazing education-wise. As we transition into the virtual interview season, a little bit different, but in terms of virtual education and then virtually selecting an exceptional resident or finding your best program and your best fit, do you have any advice for either party, the applicants and the residency selection committee, to break through the challenges of virtual interviews?
Ooh. Thanks for that really hard question.
Sorry.
That's really hard. First of all, I'll just put out there that I think that the virtual interviews are really good for the candidates from an equity standpoint.
Yeah, I totally agree.
Yeah, I think it helps our candidates from East Coast get to West Coast without having to worry about plane changes, missing it, or missing out completely because of financial reasons. So I think that it's important. But then the challenge is just like you just said. The challenge is, how do we really assess the candidate, and how does the candidate assess us as a program? I'm not sure I've got anything really unique, but I think that now, again, since I've said before, everything's pass-fail for the students in the School of Medicine now. What differentiates them now is research, letters of recommendation, and life lessons. So their distance traveled, or some of their journey, a story behind the journeys that they've been on. So what I like to ask is, I might pick a research project or a publication, and although I can read the publication and we could talk about the science behind it or the results, what was fascinating about it, what was surprising about it, instead I like to ask, what are the intangibles that you've learned about this particular project? Or what was something that you gained from being part of this 3-year longitudinal study? A lot of times I'll talk about communication styles. They'll talk about their organizational skills. So they'll get them talking about the life skills that they're going to now bring into my residency program. So I want to hear about that. As for a candidate, that's really hard too, because it's hard to really get a sense of culture, of how we're going to challenge the resident. I think that the candidates really need to be asking questions of our alumni, of current residents, go to the meet and greets. I know a lot of candidates came to our Vanderbilt friends and alumni gathering that we had at Academy. So I think that was a really useful time for them to meet some people there. But I would say that if I were to be a candidate trying to figure out the program, one question I probably would ask is for explicit examples. For example, do you have an example of a time where a resident needed a lot of support, and how did the program handle it? I think that gives an idea of what kind of support, emotional, psychological safety there may be in that type of a learning environment. But this is really tough, Andrea. So I don't know if I have all the answers for this.
No, it's all great advice. It's a really tough situation for both parties, I think.
Yeah. And if open houses are still available, I think the candidates should be going to the open houses if they can.
Yeah.
Once medical students match, or even during medical students, so often we have opportunities to mentor them. I understand you have some expertise and joy regarding mentor-mentee relationships. You gave an advice over Zoom interviewing, but once you have someone that's dedicated to ophthalmology in medical school, or a resident that you're connecting with, tips on how to be a good mentor and how to pour into them, be responsive, connect enough. What's your perspective on that role as you've taken them on in your career?
Thank you. I love this topic. I think that a mentor-mentee relationship is only successful when both parties contribute to the relationship. Otherwise, it's an advisor-advisee relationship where it's only unidirectional. It really needs to be it needs to be bidirectional, and there should be expectations that are set. So usually, I have a mentoring contract. I've seen multiple examples that are really complicated, some that are really simple, and you can just design a mentoring contract that fits your needs or what that mentee needs for that particular topic or for that particular journey. I think it's important for us to meet regularly. And one of my expectations of my mentees is that they contact me and they are in charge of the timing, because I will probably forget whether or not it's been time for us to meet, and it's up to them to make sure that we actually have that meeting and they come with an agenda. And I do this with my mentoring committee. I'm on faculty. I have a mentoring committee. And so I do the same thing. I bring an agenda of what I want to talk about and what are my short-term goals and my long-term goals. And that gives them an idea of how to shape that conversation and to figure out what resources I need to be tapping into. Who do I need to meet? What meeting should I be applying for? I do the same thing with my mentees. I want to hear what their goals are, 5-year, 10-year goals, and what are they interested in, what's bothering them right now. So that gives me an opportunity to see it in writing, have them put it in paper, and so that I can see it in writing, and then I can be able to appropriately use that time wisely. I think that mentors also have a lot of bias too. So I think it's very important for us to recognize our biases, and make sure that that doesn't get inserted into our relationship. I also disagree that there should be a supervisory type of hierarchy in the mentor-mentee relationship. For example, I would not want my boss to be my mentor, and I wouldn't want the residency director directly to be a mentor for a resident, because there could be that hierarchy that can really make that relationship difficult.
I know someone has said that it's good to have mentor-mentee relationships at different layers of our professional circle and even personal. And so being similar learning, as you're saying, feedback with someone younger than you in faculty, someone at your same level, and then certainly someone more senior, and be sharing wisdom, be sharing creativity, be sharing joy across each of those relationships, as you've spoken to the importance of this as a two-way street to build together.
And I think it's Sophie Bakri that taught me the term reverse mentoring, referring to the more junior person does have something to offer to someone more senior to them.
Absolutely. I get such great advice from our residents and medical students. They teach me everything. It's great. Janice, can you also break down, I know you're really good at these differentiations between a mentor, a sponsor, a coach, and how we need all of those things. I love how you differentiate those. I think it's really helpful.
So I think you need a board of trustees, and that board of trustees should include 7 people. So the 7 people are: 1, you need a role model; 2, advisor; 3, a coach; 4, a mentor; 5, a sponsor; 6, you need your peers; and 7, you need a cheerleader. And I think about the cheerleader being your family, your parents, your rah-rahs, people who are going to, no matter what you do, they're going to cheer you on, right? So that's really fun to have a cheerleader in your board of trustees. when I think about advisors are those who talk to you, and mentors are those who talk with you. They hear what goals you have and they help you sort that out and help you navigate. They invest in you. And sponsors actually talk about you. So sponsors are the ones that are putting your name out there to committees for an award, for task force, to maybe consider writing a paper or a review with you. And someone who is going to throw your name out there with nothing in return. It's not something that's transactional. And so I think that it's really important for trainees or even professionals now who have sponsors to be able to share with those people that things that you're interested in doing. For example, maybe I wanted to be part of the ABO. Maybe I wanted to be a board examiner, but no one will know that unless I speak about my interests and my desires. So I should be able to have a relationship that's authentic and vulnerable with both mentors and sponsors, so that when that opportunity comes up, my name can come up, right? So that's how sponsorship can happen very naturally and very organically.
I love this. And you can have it at all stages of your career, but it's something we don't intentionally think about, forming this board of trustees, but I love it.
So which one of those trustees do people miss the most?
Ooh, good question.
Miss as in they don't,
Meaning, like they're not aware that they don't have, or they are aware and there's not someone in their circle being that for them. Like when you think through people's lives and say, this would be the ideal support team, how often do you see someone just lacking mentorship or lacking the sponsor or lacking, which of the ones are the areas that we need to foster more?
I do think it's the mentorship part. Again, I think because of the nuances and the uniqueness of the relationships, if we're not holding up our end of the relationship, then that mentorship relationship probably turns into more of a seasonal advisorship, for example. So I think that as mentees, we probably aren't really tapping into our mentors as much as we should on a regular basis, and really investing in our relationship for them to get to know us and for us to get to know them. I bet you that's probably the answer. But then I also think that if we're not speaking up vulnerably about what we're interested in doing, what our goals are with others, then we don't have sponsors who are listening carefully for opportunities. So I think that there's a little bit of both there. Mentor and sponsor could be enhanced.
This is absolutely terrific. Thank you so much, Dr. Law, for sharing your wisdom. You're so inspiring. We really appreciate it. And I think that this conversation will resonate with medical students, residents, those early in training, and those in a seasoned career who need to update their board of advisors.
Or update my
board of
PowerPoint to have more solid, more questionnaires.
Yes, I love it.
It's just part of slowing down in our practices and being intentional, being communicative about how to improve as we seek to pour into others around us, whether students or residents, in this case, medical students in particular, in the richest way. So thank you for helping us.
Thank you so much.
Thank you. I've enjoyed my time with you too. Thank you.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website.
Thank you for listening, and we definitely look forward to sharing more